Hello, and thank you for checking out FirstcallID Approach to Staphylococcus aureus Bacteremia. My name is Paul Bunce, and I'm an ID physician. We'll be spending about the next 10 to 15 minutes going over some of the key aspects of an ID consultation for Staphylococcus aureus Bacteremia. If you haven't done so already, please check out our first session on how to do an infectious diseases consultation, which covers a lot of the basics of ID consultations in general, whereas this session really focuses on the specifics of Staph aureus Bacteremia. And before we move forward, just a quick reminder, this content is for educational purposes only. Please refer to current guidelines or use your professional judgment in your own clinical practice. So the key aspects of our initial assessment of patients with Staphylococcus aureus Bacteremia. So first is an evaluation that focuses on identifying the presumed source of the bacteremia, as well as signs or clues to possible deep-seated infection or cases where further interventions are required. Our history focuses on any localizing symptoms of infection. We take the Duke criteria into account when assessing for infective endocarditis, in addition to our standard history and treatment to date. The examination highlights the evaluation for stigmata of endocarditis or endovascular infection in general, categorizing vascular access devices and lines, as well as evidence of musculoskeletal inflammation. The investigations of note, so in addition to routine blood work, serial blood cultures to assess for sustained bacteremia, as well as clinically guided imaging, and in almost all patients, echocardiograms. Our summary and recommendations, we must define the specific syndrome. We suggest appropriate and optimal antimicrobial therapy based on the microbiology information we have at the time, usually leaving the duration until later. We highlight the need for any immediate interventions that are recommended, as well as further investigations moving forward. So the first point, and this is just a highlight that when we are assessing patients with Staphylococcus aureus Bacteremia, we're really looking at two things: identifying the presumed or likely source of the bacteremia, and more importantly, signs or evidence of deep-seated infection or cases where we're going to need to offer some type of intervention. The source is almost always the skin, whether it's through a wound, abrasions, lines, or breakdown in the skin of some kind. That's usually the case. Occasionally, it's through the lungs in a patient with pneumonia, and often there's no clear or obvious source of infection or mechanism of how the patient became bacteremic. I'll highlight that Staphylococcus aureus Bacteremia has a high mortality rate, even with our optimal care. Rates estimated in the 20 to 30% range, depending on the specific situation that it's being encountered in. There are worse outcomes in patients with delayed or inadequate treatment. The bacteremia, especially if sustained, can lead to deep-seated infections such as infective endocarditis, but also bone and joint infections, so vertebral osteomyelitis, septic arthritis, spinal epidural abscess are just a few examples. And there's increasing morbidity and mortality associated with these deep-seated infections, as well as an increased recommended duration of antibiotics. And our failure to identify and treat these deep-seated infections can lead to a persistent bacteremia and even more complications down the road. Our history focuses on localizing symptoms of infection, components of the Duke criteria, in addition to our standard history and treatment to date and response to treatment. We want to get a sense of their timeline of their symptoms. We'll ask specifically about musculoskeletal symptoms, cardiac or respiratory symptoms suggestive of heart failure. Our standard medical history also includes things like comorbidities, medications, possible immunosuppressants, social history, and careful attention to any history of injection drug use. Our examination, in addition to our general examination, always includes the evaluation for stigmata of endovascular infection, so looking at the hands and the feet for any evidence of embolic or immunologic phenomena. We want to characterize if there is fever and the pattern of fever over time. And we always want to categorize or catalog the presence of any endovascular lines or vascular devices, be it central lines, peripheral IV access, and any implantable devices as well. Also paying attention to prior lines and prior sites of IVs, because that also can be a potential source for the infection. In terms of investigation, so we look at routine blood work. I'll mention that inflammatory markers are often of limited value in assessing the sort of severity of illness and also the likelihood of complications. We do pay a lot of attention to microbiology. If we don't know the susceptibility state of the organism, assessing for risk factors for MRSA, and just when we're trying to decide whether to empirically cover for MRSA or cover for MSSA. We'll often compare bloodstream isolates to peripheral sites. So if someone has a wound and it's known to be colonized or infected with methicillin susceptible Staph aureus, that increases the likelihood that the bacterium is also the same type of isolate. We'll also want to do serial blood cultures. I generally don't like daily blood cultures, but the point is that you want to assess for the presence of a sustained bacteremia, which increases the probability of an endovascular infection. We also want to follow serial blood cultures to document clearance of the bacteremia. Echocardiograms are usually a standard in almost all patients with Staph aureus bacteremia. The exact type of echocardiogram, be it transthoracic or transesophageal, or the order in which you do them, if you do both, depends on what's available and the clinical context. Also, how likely is the test result going to change your management? Usually we begin with a transthoracic echocardiogram, and then based on the results and the clinical course, we can decide what the next best step is. Diagnostic imaging is really based on the patient's symptoms and our concern for possible metastatic foci of infection. So if we're worried about septic pulmonary emboli, we'll get a CT of the chest. We can do spinal imaging with CT or MRI, recognizing that often a spinal epidural abscess will be virtually invisible on a CT and require an MRI to identify. In some institutions, PET scan is more routinely or commonly available, and the evidence supporting the use of PET scans in terms of improving outcomes in patients with Staph aureus bacteremia is in evolution. So I'll say that may be something that you can consider if it's available. When you provide your summary and recommendations as a consultant, the key things you want to include, so you'll define the syndrome, right? Is this a presumed complicated or presumed uncomplicated Staphylococcus aureus bacteremia? Is this a community or nosocomial infection? A little bit about the host, and you can outline at this point our concern for how likely there is to be metastatic infection or seeding of other locations in the body. Our suggestions will highlight the optimal antimicrobial therapy based on the susceptibilities or our presumed susceptibilities at the time. Usually at this point, we'll leave the duration to be determined. We'll highlight the need for any immediate interventions, so remove any central venous catheters if feasible, drainage of abscesses, or sometimes even more invasive procedures. We'll highlight recommended further investigations, usually in terms of imaging. We'll highlight the need for repeat blood cultures. Usually I'll say repeat 2 sets after 24 to 48 hours of antimicrobial therapy, and then repeat those if any of the further blood cultures are positive. Imaging, again, guided based on the patient's symptoms and our concern for deep-seated infection. And one thing I often include in my initial assessment is the sort of optimal timing for central line placement. So often patients will require PICC lines or peripherally inserted central catheters for long-term antibiotic administration. And the issue is there's some caution in putting in a PICC line in patients who have an ongoing bacteremia because of concern for seeding the PICC line. And so often what I'll say is defer PICC line until we have the patients have negative blood cultures for at least 48 hours to lower the risk for seeding of the PICC line. And so my usual sort of standard statement is duration and route of therapy to be determined based on clinical course, clearance of bacteremia, and the results of investigations. So as I leave up a summary of the key points of the ID consultation on patients with Staph aureus bacteremia, I just want to highlight a couple of extra points. The first is that as much energy and attention gets paid to the initial assessment of patients with Staph aureus bacteremia, the real challenge often lies in the next steps. You know, in patients with complications or failure to clear their bacteremia after 5 or 7 days, right? Or these patients where they have multiple foci of infection and you're trying to manage these things concurrently, right? Your patient has infective endocarditis where they might require a heart valve to be replaced, but they also have a concurrent septic joint that needs to be washed out before they do the heart valve, right? So just coordinating these things can be really challenging, and we can help navigate that. The second is that Staph aureus bacteremia is a mandatory ID consult in most of the places where I have worked since I became an ID consultant. And I'll still say that with every case that I see, there's always nuance and always something to be gleaned, and no 2 cases are the same. And you know, even with a lot of experience, Staph aureus bacteremia can humble even the most experienced and wisest clinician. The third is that, you know, this is a bit of my bias, is that a lot of energy is spent on, you know, what is the optimal antimicrobial therapy, either single drug or combination antibiotic for treating patients with Staph aureus bacteremia. And I think sometimes at the expense of focusing on the necessity for adequate and timely source control. And so I think it's something to make sure that we're paying attention to is not just what the antibiotics should they be on, but achieving and advocating for source control when it's necessary. But honestly, anything that improves outcomes for this particular infection is welcomed. So in terms of resources, there are many very good resources on the topic. Here are just a couple that I can sort of advocate for. So first is the Contemporary Management of Staphylococcus aureus Bacteremia, Controversies in Clinical Practice, which highlights a number of the key sort of dilemmas or debates that we have in our field about the optimal management and evaluation of patients with Staph aureus Bacteremia. And the second is just a very nicely laid out, well-written review on the topic, Management of Staphylococcus aureus Bacteremia, a review. So that's all for now. I'm Paul Bunce, and I want to thank you again for watching the session. If you have any feedback for the session or the project overall, just let us know. And if you find this helpful, please share it and tell a friend. Take care.